I would like to welcome Professor Claudio Babiloni, who is going to talk on Alzheimer's disease dark side and then give a talk on biomarkers of resting state EEG rhythms. So, Professor, please.
Okay, thank you very much for the introduction. In the Global Brain Consortium, we have a work group, Global Brain Consortium Dementia Work Group, and we are happy if you be in touch with me and my co-chair of the work group, Professor Gottschalk Jenner, in order to discuss initiatives in this framework. The title of my presentation is Biomarker of Resting State EEG Rhythms of Vigilance Dysfunctions in Alzheimer's and Related Diseases. These are my co-workers. The next presentation by Professor Gottschalk Jenner will be focused on the EEG. Dementia is a clinical manifestation characterized by severe cognitive impairment and disability in daily living activities. And a major role to generate dementia is from neurodegenerative progressive diseases such as Alzheimer's disease, dementia with Lewy body, or Parkinson disease. Clinicians want to measure the cognitive deficits in several dimensions, for example, reasoning, memory, problem solving, spatial language, and so on. And this is the focus of neuropsychological testing. And you see that there are some overlap in the cognitive deficits for different neurodegenerative diseases. The proposal of my presentation is that there is a dark side in the evaluation of disorders in Alzheimer's disease patients. And this dark side is the level of vigilance and consciousness. You see in this picture in light brown that there is a physiological transition from deep sleep to light sleep or drowsiness or the vigilance and conscious experience in a healthy subject. And our proposal is that Alzheimer's disease and the related disorders have a very significant effects on the regulation of vigilance. And that this is a dark side because it's not measured according to the clinical guidelines, no EEG in the clinical guidelines. In reality, you can very easily measure the abnormalities in the regulation of quiet vigilance by resting state, eyes closed, and eyes open condition. And you see here a person receiving a recording of resting state EEG, and is represented the highest oscillation at about 813 Hertz alpha frequencies in healthy subjects in quiet vigilance, eyes closed. And this is due to interaction between thalamus and cerebral cortex. But this thalamocortical loop is modulated by ascending subcortical systems, including the reticular formation and midbrain, hypothalamus, and projections to thalamocortical circuits. So you see that dopamine systems or acetylcholine systems or noradrenaline systems can modulate the cortical arousal and vigilance in healthy subjects. And today you can easily investigate the cortical sources of EEG rhythms by several freeware tools, including Iloreta. And so you see that artifact-free EEG signals can be used as an input, and you can estimate the current intensity in the mathematical sources in the cortical model of Iloreta. And in a previous European project, Pharmacog, we analyzed the cortical sources of resting state closed EEG rings. And in patients with mild cognitive impairment, so before dementia, and due to Alzheimer's disease as revealed by cerebrospinal fluid, and with a contrast with patients with mild cognitive impairment, not due to Alzheimer's disease, but for example, Lewy body dementia or frontotemporal dementia. And you see the typical representation. In the vertical axis, you have the intensity of the cortical source activity. In the horizontal, you have the frequency bands, delta, theta to gamma, and the rectangles are the cortical source region of interest. And you see that in blue, we have a mild cognitive impairment, not due to Alzheimer's disease, and they have the maximum cortical source activity in the alpha range and the posterior areas, parietal and occipital. And at the group level, there was a significant decrease of cortical sources of alpha rings in the occipital and the parietal areas, and an increase of delta low frequency source activity in the temporal region. So we could conclude that Alzheimer's disease neuropathology can be related to a decrease of alpha rings in the resting state as closed, as a demonstration of a particular dysregulation of white vigilance in this patient in the clinical stage preceding dementia. We repeated the experiment comparing the cortical sources of resting state EEG rings in Alzheimer's disease MCI mild cognitive impairment patients against mild cognitive impairment due to Parkinson's disease. And you see that in the have an abnormal decrease of cortical sources of alpha rings in the occipital, parietal, and temporal regions of interest, but the bigger drop of alpha source activity is in the parietal, occipital, and temporal areas in Alzheimer's disease versus Parkinson's disease MCI. In contrast, there is an increase of delta source activity in parietal region in Parkinson's disease MCI in relation to Alzheimer's disease MCI. So there is a different profile in the low frequency, more abnormal in Parkinson's disease MCI, than alpha rings, more abnormal in Alzheimer's disease MCI. So again, differences in the abnormalities in this patient. Another experiment compared the Alzheimer's disease MCI and MCI patients due to Lewy body. And we have a very similar result in relation to the previous slide. And so you see a clear drop of alpha rings in both Alzheimer's disease and Lewy body MCI patients, but the bigger drop in Alzheimer's disease MCI patients. And in contrast, more abnormalities in delta source activity in Lewy body MCI with respect to Alzheimer's MCI. So again, similarities between Lewy body and Parkinson in relation to Alzheimer's disease MCI patients. Another important aspect is that these abnormalities in the resting state EEG rings are dependent on age of the old people with Alzheimer's disease and mild cognitive impairment. You see very clearly that if you stratify the Alzheimer's disease MCI patients in relation to the age, for example, younger people in orange, middle age in violet and older age in green, you see that the reduction of alpha source activity is greater in the younger Alzheimer's disease MCI patients. This means that if you are young, for example, 60-year-old, and you have a diagnosis of Alzheimer's disease MCI, you have a more abnormal generation of alpha renin. So a more aggressive Alzheimer's disease in relation to patients with Alzheimer's disease MCI, but at older age. And you see that also the education, the years of education, of formal education, are related to the generation of alpha rins and regulation of vigilance. And you see that in the bottom that you have in red Alzheimer's disease MCI patients with a higher education in comparison with Alzheimer's disease patients in orange with lower education. And you see that there is significant, more abnormal alpha source activity in patients with more education. This means that even if they have similar cognitive deficits in the two subgroups of Alzheimer's disease MCI, the patients with more education have more abnormal alpha, which means that their education and neural correlates of higher education can compensate the abnormalities in the regulation of vigilance. A final experiment was focused on recognition, detection of epileptiform activity in Alzheimer's disease MCI patients. And here you see 8 Alzheimer's disease MCI patients showing some kind of epileptiform activity in the resting state, eyes closed EEG activity. They fit 4 out of 6 criteria for interictal epileptiform abnormality. And when you compare Alzheimer's disease patients with this kind of epileptiform activity in green and patients with Alzheimer's disease MCI but no epileptiform activity in red, you see that you have no significant difference in alpha between the two groups, but you see that the patients with Alzheimer's disease MCI and epileptiform activity showed higher delta source activity in occipital and temporal areas in comparison with
hello, Professor.
MCI.
Sorry to interrupt you. You have 2 minutes left for your talk. Thank you.
Okay, thank you. And so we concluded that in the evaluation of Alzheimer's disease patients, you of course have to use biomarkers for the diagnosis, for example, amyloid and tauopathy with cerebrospinal fluid, or amyloid PET and tau PET for the diagnosis. But if you want to evaluate the impact of this neuropathology in the systems regulating vigilance, you have to use EEG as a natural measure of neuroregulation of vigilance. So thanks a lot for your attention. And I kindly ask Professor Gorchev-Janer to upload her presentation and start.
Thank you. Now I would like to share. Yes, I think you can see it now.
Yes,
Yes.
I'm
can
trying.
see. Yes.
Yes.
Full screen mode, please.
Oops.
Okay.
Sorry. Okay. thank you very much for this great talk, and thank you for the kind invitation. I would like to talk about cognitive event-related EEG oscillations in Alzheimer's and related diseases. We all know now that we can detect Alzheimer's disease by biomarkers 1 to 2 decades before the clinical presentation. And there are amyloid, tau, and neurodegeneration markers, but all of our group aims to put EEG into this frame if we can, and we are trying hard for it, because we have a nice example. In 2017, EEG became part of diagnostic criteria in dementia with Lewy bodies. And what is event-related potentials? They are measured brain response to specific sensory, cognitive, or motor event, and reflects cognitive or sensory network activity. And if you administer some mathematical procedures like Fourier or wavelet analysis, you end up with event-related oscillations, and these frequency bands are related to certain cognitive domains. So let's start with risk factors for AD. This is a risk study from our group showing P300, a reliable and effective tool. And in people, healthy people over 50 years old, and with normal MRI, normal NPT, and neurological or psychiatric exam, we can clearly see gender and age matter, and we see higher responses in females and lower responses in aged group. And also depression is an important part. Clinically, otherwise healthy elderly people with relatively higher depression scores display lower amplitudes similar to MCI patients, as you can see from here. And also obstructive sleep apnea, which is a modifiable risk factor, shows similar electrophysiological profile of P300 or event-related oscillations similar to amnestic MCI, even though they have totally normal neuropsychological tests. So let's move on to Alzheimer's disease. This is a very nice depiction of P300 across MCI, healthy people, and AD, and there is a nice continuum along the Alzheimer's disease. And you can see the same continuum in event-related oscillations as repeatedly our group has shown in delta event-related oscillations. You can also check sensory versus cognitive networks, and you can check progression of disease. Here in amnestic MCI patients, you cannot see any difference between sensory responses. This is not, this is a passive oddball task with no cognitive task is given. And this one, when you give a cognitive task, the groups differ very nicely. And when you look at the longitudinal event-related oscillations for 1 year, you can differ. You can see the difference between stable MCI versus progressive MCI, about 31% decrement in progressive MCI at the baseline. And if you follow progressive MCI from the baseline to 1 year, you can see a further 30% decrement over time. Also, you can see the neurodegeneration can be reflected by event-related oscillations in healthy controls and mild cognitive impairment. When frontal volume decreases or gets atrophied, you have lower frontal delta responses in this population. clearly connectivity is impaired in cognitive disorders. Under physiological conditions, cognitive tasks increases delta and theta arrow connectivity under normal connections, under normal conditions. And in Alzheimer's disease, clearly it is expected that this connectivity must be decreased, and that's what happens. Delta, theta, and alpha event-related connectivity decreases in Alzheimer's disease, and cholinergic treatment increases alpha connectivity a little bit toward the healthy controls. And what's more, gamma event-related coherence is increased by cholinergic medication. In resting EEG connectivity, it's another story. In resting EEG, there are various studies showing at the very early phase, hyperconnectivity occurs. This is a nice paper. Hyperconnectivity starts first, and then when the neurodegeneration starts with advanced structural atrophy, connectivity is decreased. So this is Laura Bonanni's paper showing hyperconnectivity occurs at the very early phases of degenerative conditions in anterior regions in FTD and posterior regions in AD. And our group has shown last year that resting state EEG theta connectivity increases at MCI stage and decreases at dementia stage. And this is another very nice paper showing the underlying mechanisms related to oscillatory activity in delta and theta frequency bands, which is related to increases in amyloid beta at the earliest phases, and in later phases of disease, alpha and beta frequency bands are reduced, possibly due to more influenced by, more mediated by tau peptides. So at the somewhere between on alpha and beta frequency bands, amyloid beta and tau has opposing effects. Also, you can check treatment effects by means of EEG, event-related oscillations. This is our iStart EPIA paper of AAIC showing cholinergic drugs modulate theta and gamma arrow. Here is in cholinergic modulation, you can see increased theta phase lacking. This is the Alzheimer patients de novo, and these are the cholinergic medicated patients. And you can see theta phase lacking. And as I told before, gamma activity is increased in medicated Alzheimer patients by cholinergic drugs. And we use also a memantine, which is added to cholinergic drugs in moderate AD or in mild, starting from mild AD in many cases. And you can alterations can be seen theta, gamma, and delta in resting state entropy measures. Another story is neuromodulation. Slowing of theta oscillations by means of individualized theta frequency talks, current stimulation improves memory in healthy people. So this is a very important study showing you can measure individualized theta and use neuromodulation according to that. Let's move on to Parkinson's disease. Similar to Alzheimer's disease, we can see cognitive impairment in Parkinson's disease is reflected as with a gradual decrease across Parkinson's disease with normal cognition, PD-MCI, and PD dementia. And also electrophysiological evidence between differentiation between auditory and visual networks in PD can be observed by means of event-related oscillations, because Parkinson's disease shows deeper visual abnormality than auditory. And so this one is also a P300 reflection of neurodegeneration in PD-MCI, because with decreased P3 amplitude, we have reduced putamen volume associated with it. This is another recent paper showing reduced power and phase locking values accompanied by thalamus, putamen, and hippocampus atrophy in MCI, PD-MCI. And what's more, we can easily say that in PD, cognitively normal PD, phase in delta and alpha arrow decreases first. And when the patients are in PD-MCI stage, phase and power decreases, deeper decreases are seen in all frequency bands. What's more, thalamus volume is related with P300 latency and delta and theta arrow power, whereas putamen volume is associated with neuropsych measurements. So thalamus has this critical role, as stated by this very nice review, narrating models for Parkinson's disease, clearly affected by this striatal thalamus effects on thalamus. To compare the difference between Parkinson's MCIs and AD MCIs, there is a comparison showing at the occipital parts of brain, as it can be seen from many PET studies, glucose PET studies, there is an overexcitability of AD MCI in the occipital region, like here, increased occipital responses to visual arrows and coexcitable occipital region in PD-MCI. This is such a nice reflection of pathophysiology.
Hello, Professor. Sorry to interrupt you. You have 2 minutes for your talk. Thank you.
Okay, thank you. So we also see the difference in abnormal cross-frequency coupling in PD-MCI. So as a whole group, we continue efforts towards data sharing and harmonization. And I thank to Josephine Cruz for this nice slide sharing with me. And there is a call for consensus in all these papers from Prado et al., Para Rodriguez et al., Lipnicki et al., Engemann, and Güntekin et al. So we propose, as Claudio stated, pathophysiology of P markers in the ATN model to become ATPN model. I thank my mentor and all my colleagues, Bahar, and all other team members, all of them, and our international collaborators. And we certainly thank to all of our volunteers and our funding agencies. Thank you for your attention.
Thanks a lot, Gosha, for this very, very impressive series of studies. I kindly ask Mario Parra, Bahar Guntin, and Josefina Cruzat to appears. And I kindly ask Bahar to moderate the discussion of what we observed in this presentation, but also in the literature findings on the EEG biomarkers of vigilance and cognition from different groups.
Yeah, okay, thank you very much. Actually, this is a very good combination of all researchers from all over the world, and although the time is different and not easy. So as we listen from Claudio and Gersa, we have lots of things in the spontaneous EEG and event-related oscillations. And in the spontaneous EEG, most of them is the degrees of alpha and degrees of delta, theta. And also in the event-related, we can see that the event-related delta theta responses decrease, opposite of the spontaneous EEG, because the dynamics are not the same with the event-related and spontaneous. But the phase locking is important, and the event-related coherence is important, and the power spectrum is important. So there are very robust findings. And actually, these groups are, we have lots of data from all over the world, and with the European group as led by Babiglioni and Parras and Ibanez group. So we can come all together in order to see this in global view, and we can share data, and we can achieve the goal, as Claudio and Gersa mentioned, that this could be a biomarker. So this is my word, and I would also ask Parra and Josefina, Mario and Josefina. So maybe Mario, you can.
Yeah, absolutely. Thank you, Bahar, and thank you, Claudio, Gorsef as well. Fantastic presentation, really encouraging evidence, so, highlighting the potential that this methodology holds for the better characterization of these neurodegenerative diseases, as Claudio has been emphatically highlighting throughout his presentations and recent interaction. I think it's great to see that there are many different electrophysiological approaches drawn from EEG, specifically, that can shed new insights about the mechanism of these processes. I particularly like the proposal that Claudio and Gorsef ended up with regarding a suggestion to revise the classification approaches from a biological perspective regarding these neurodegenerative diseases, particularly Alzheimer's disease, whereby they are recommending to add the P to the framework in order to capture the contribution that these novel methodologies are making, unquestionably making to this particular approach. I have a few questions about that, but obviously we can follow after the audience have asked questions, but I think this is very encouraging. I think that as the evidence piles up, so does the challenges, because it's clear that different neurophysiological methodologies are yielding promising but quite different findings as well, which can be clearly distinguished across different types of neurodegenerative diseases, but also when in the continuum of these diseases we are seeing patients, assessing them. I think I totally agree with you, Bahar. It's time to come together in this comprehensive framework to start exploring which of these tools or combination of tools can better inform about potential electrophysiological phenotypes or risk. Different phenotype can help us, for example, in the early identification of this problem or diagnosis, but as Gorsef said, also showed in the monitoring of these patients to particular treatments, whether pharmacological, as Gorsef showed, but also non-pharmacological, especially considering the growth in the area of risk factor, brain health, and non-pharmacological intervention for these neurodegenerative diseases. These are very general comments. I have a few questions to ask as part of this discussion, but I will pass on to whoever is next. Who is
Josefina? Okay, Dan. Josefina, yes.
Okay, thank you. And thank you, Claudio, and thank you, Gorsef, for your presentations. I think you have shown a lot of fantastic research on EEG and dementia, and that all this research have shown emerging methods and results that show remarkable accuracy in mapping and predicting the altered neural dynamics in dementia. And I think that all these results have like a lot of potential to offer these electrophysiological biomarkers of Alzheimer, with of course preclinical and clinical applications. And it's very interesting that all this decrease in eye close, resting state alpha is related to Alzheimer. Posterior alpha relates to Alzheimer and differentiates among Alzheimer and Parkinson. Global alpha, Claudio showed that it's more abnormal in youngest, but also in educated subjects. And also, Gorsef nicely showed that all these altered event-related oscillations and also the abnormal EEG connectivity are related to Alzheimer. And it's very interesting that all these new insights can be used as a ground for using like novel treatments, such as using neuromodulation for modulating an Alzheimer. And I want to add to this discussion that it's very relevant that we can integrate all these results, all this data into whole brain models in order to investigate the specific mechanisms that underlie these abnormalities in EEG, and that they also have the potential to inform on the novel biomarkers of Alzheimer. And I think that we can discuss the possibility of incorporating them in the discussion.
Okay, thank you very much. That's great. So these points are also important to bringing all together these markers with machine learning approaches, and also it could also be used for individualized, treatments. The EEG could be used as, for that too. So are there any questions from the audience? Does anyone has any questions? Okay, it doesn't seem that we have any questions. So I will, Gorsef and Claudio, I know Mario has questions, but first Claudio has raised his hand and
first,
please,
yes, Claudio goes first.
Okay, so I have two questions for the discussants and also Gorsef. About the first, if what we observe some changes in the event-related oscillations in relation to the treatment, cholinergic treatment, we can see clearly that the groups show different abnormality, less abnormality in people taking the cholinergic drug. But we know that cholinergic drug is not active on all patients, but just on about 50% of the patients, showing some clinical improvement, some improvement in the cognition. So my question is, these changes of EEG are related to some concrete cognitive improvement in the patients in relation to these changes of EEG, event-related EEG. This was the first point. And the second point is a bit provocative regarding the diagnostic value, because there are two different concepts between the describing an abnormality in the neural system and to attribute this abnormality to an intrinsic neuropathology specific of a given disease. Let me know your view.
Am I asked? I couldn't understand.
Yes,
the voice is not.
Yeah, the question
Okay.
is for you, Gorsef.
Okay, I understood the first one. The second one, maybe you can repeat. First of all, cholinergic medication related to event-related changes. The theta changes and it moves toward the healthy people, cholinergic medication. However, gamma is already increased in Alzheimer's event-related oscillations in our group, and cholinergic medication moves it even more. So I don't know whether
but
this
the
gamma.
point is, you see that when you have the normalization of the almost normalization of mental oscillation. We have also an improvement in mini-mental state evaluation score or memory score. If there is a statistical correlation between.
Yeah, that's the clinical association of event-related oscillations. Well, in this EEG event-related study, the treatment effects were not correlated with mini-mental state because it's a very crude scoring system, mini-mental state. And it was earlier study, and we didn't have an extensive battery of neuropsych testing. So we certainly have to do that again in a wide group to confirm our results. So I cannot say that it is confirmed. So that was an old data, and we couldn't confirm it because it's very hard to do it de novo patient and then do it again after maybe taking 1 year after. So yeah, maybe other groups would be willing to do that with us.
We have 5 minutes left, and there's one question. Also, there's Mario. Matthias Eisen will have this question, please.
Can you hear me?
Yes.
Hi, thanks to both speakers. I wanted to get your views on basically, we saw both basically possible biomarkers for resting state, but also during cognitive tasks. And I wanted to know how you think they compare. So is it that actually it is the connectivity?
Okay, so I can say just the resting state is something different, but in event-related visual paradigms gives a very important clue, and we have several times shown that, especially the event-related theta and data responses are very, very robust findings that we can find. But when you apply a different task, so the cognitive paradigms, you can analyze what you really want to show. You can look at the facial expressions, and then the differentiation occurs in the front parieto-occipital, but if you do a cognitive paradigm, it is in the fronto-central. So they are, of course, they give lots of different things. But if you want to understand some specific cognitive function of this group, then event-related is better, but the spontaneous also gives very important findings, and also the connectivity analysis and so on. So maybe Claudio or others could also respond on that.
I ask Mario and Josefina to reply.
I just want, this is a fantastic question. I think it's such an important question at the moment, especially in this, with the search of metrics. We are witnessing some unstoppable. Every day we see new and equally promising. So we are kind of working on that front at the moment, Matthias. So I think we are doing within the Eurolab EEG consortium is precisely to try to address questions like that, because they do require big sample sizes. So that's not a question you can address with a few tens of participants. You need large samples. So Eurolab EEG is a consortium that has brought together partners from around the globe that are contributing data. We have at the moment probably more than 2,000 EEG recording from different types, including middle age and older people who are healthy, but also people with different type of risk profile of MCI.
Hello, Professor. Sorry to interrupt you. You have 2 minutes left for your discussion. Thank you.
Yeah. Thank you, Sherry. And we have also different type of dementia of different variants, sporadic. So with the heterogeneity of this cohort that we have put together, and also with the wealth of EEG approaches, because we have resting EEG, we have task-related EEG, and we have task-related EEG using different type of paradigms. Gladly to say that most of the paradigms included are now published as promising marker, cognitive marker, combined with EEG. We hope we will shed new lights about questions such as the one you're asking, Matthias. If we enter all these metrics into a machine learning algorithm, and this is something that Agustin Ibanez group is taking care of. They're really focusing on the Eurolab data, running sophisticated new pipelines developed by the group to extract this precise phenotypic characteristic that can be informative about risk, but also about disease presence. So then we are hopeful that we will shortly start contributing some insight about whether your question have clear-cut answer to provide. We believe it does, but we are not quite there yet. At least we need this data to come out. And then the plan is to join effort with the Global Brain Consortium to bring this data set together, plus all the data that is coming through the consortium. So going forward, we are planning to provide this large data set, but also some tentative tools that people can get hold of and start trying with our own data set as well.
And I just want, before we finish, and I just want to add to what Mario just nicely said, that thanks to this massive data set, we now have the possibility, and more research have shown, that sex is important to be considered as a variable, as some studies have shown, like clear differences in different metrics between males and females. So this is something good that has been coming out also.
Brilliant.
Yes. Okay, thank you. Claudio, would you like to finish? Because we have out of time, I think. Maybe you will say the last word. Claudio?
Yes, thanks a lot for this nice discussion and your participation. And thanks a lot. Be in touch with us, with the Dementia Work Group of a Global Brain Consortium. And we are in strict cooperation with Latin American Dementia Work Group to generate new initiatives. Thank you very much.
Thank you, Claudia.
Okay. Thank you so much, Professor.
Thank you, everyone.
The whole panel and the discussants for your presentation and talk. It was very informative. Thank you so much. So moving on, we have our next professor, Maria Luisa Bringas from China-Cuba Lab of UESTC, who is going to present on QEEG in Parkinson's clinical trials. And Professor, you have 15 minutes. And if you want to have a discussion session at the end of your presentation, please spare 2 to 3 minutes from your talk so that the people can ask questions. Thank you so much. Over to you, Professor.
Today, I want to present 2 examples of QEEG in clinical trials. I would like to start mentioning that the Parkinson in this moment is one of the fastest growing disorders. But the main problem is that most of the people affected by Parkinson live in low and middle income countries. And you know, this is the meaning of this is a lot of population of patients don't have access to neurological care, to medicine, etc. And the urgency in this moment is identify new protective drugs. In our country, we have the biotechnology industry. And this could be one option for the low and middle income countries. And we identify erythropoietin because it's a new compound. It's not new, sorry. It's a compound employed for anemia, for many different disorders. But this new application for neuroprotection is started in the beginning of the 2000 year in Germany and different countries, in multiple sclerosis, in ataxia, in schizophrenia, with good results. In Cuba, you have here the Cuban Center for Immunology Studies. They have 2 new formulations for EPO. We start in 2012 using the erythropoietin human recombinant in Parkinson's disease. We published 1 clinical trial for safety using this drug, and we obtained very good results in cognition using QEEG source analysis. The QEEG source analysis was doing during the presentation of the flanker task to patients with Parkinson and the usual medication. Patients with Parkinson, beside the usual medication, they use the we gave them the EPO, and the small group for the healthy matched control. We used the Loretta to identify the source analysis, and we use EEG 64 channels. The first result we obtained was with the reaction time. In the behavior, we didn't find difference between the groups. We find difference between the 3 groups, but not between the 2 Parkinson groups. However, the ERP identified the N1, the very early component for the measure the attention before the 100 millisecond, where the Parkinson patient with the erythropoietin has the same performance, the same amplitude that the healthy controls. Besides, we employ the same procedure, and the N200, we found the difference between all the Parkinson patients versus healthy control, not between the 2 kind of Parkinson's patients. And the first conclusion is that QEEG can make the difference, the significant difference between a patient we use the EPO and the normal or usual medication. And also ERP was very efficient to detect this difference better than the behavior measurements. One thing to mention is the usual erythropoietin, unfortunately, needs high doses and prolonged application to produce the significant effect, but has adverse effect because the increased hematocrit and blood viscosity. The Cuban neurotechnology industry developed a new compound, NeuroEPO, to have the advantage to keep the same neuroprotection capabilities, but reduce the hematocrit and blood viscosity than the previous one. We use the NeuroEPO in ataxia, in healthy subjects, and in Parkinson, 3 different safety trials. And from the trial in Parkinson, we did one secondary analysis looking for the cognition and how the cognition can be mediated by the EEG. To the left, we can see the design, 15 patients with NeuroEPO and 11 in placebo group. And in the baseline, we recorded the EEG, neuropsychology battery. 6 months later, the same. And we tried to demonstrate if the EEG, the resting state EEG, could be a direct reflection of the EPO effect on the cognitive performance of the patient. The battery is here, 6 neuropsychological tests, and 1 standard EEG montage, the 19 electrodes, using the Cuban neurometric system. The results showed one important thing. First, we did one probabilistic canonical correlation analysis, because we are using latent variables. One latent variable for the cognition and other latent variable for the EEG. Usually you can find in the Parkinson research, many studies using the EEG separately, many studies using cognition separately, and we put in the same equation, in the same model, both of them. And the QEEG, the latent variable for the QEEG and the latent variable for the cognition share a common source of variance. Here we put the loadings, and the loadings of the latent variable for the QEEG can be mapped here to the right with the significant area for the different frequency bands. And we obtain a very high correlation between both of them, 0.97. And also we apply different linear mixed models to look at the NeuroEPO doses and and the relation with the cognition and the neuro-EPO with the EEG. Finally, we apply a combined mediation model where we found that the 65% of the total effect of the cognitive improvement was mediated by the EEG. But not only that, we found how the direct effect is also significant, indicating that other causes, other motivation, other factors are influencing this cognitive outcome. Could be the practice effect, could be other confounders, and this is only one intermediate analysis. We are doing more analysis about that. Here at the top, you can see the treatment, the QEEG on the neural activity mediating the cognition, and this is the direct effect. In this case, is less than could be 35%, and the mediation of the EEG is 65%. The conclusions are very simple. We, in our opinion, the QEEG is useful, affordable, non-invasive neuroimaging modality to study brain involvement in clinical trials. And this is the case of neuro-EPO and Parkinson disease, where the brain activity is mediating the cognitive performance of the patients. Now, only say thank you to our collaborators from the Cuba Neuroscience Center, from the Center for Neurological Restoration, from the USDC, from the Cuba-China Joint Lab, from UCL, Marjan, for many years, our collaborator, and for McGill, Jorge Bosch, everybody knows him. Thank you very much for your attention.
Okay, thanks a lot for this very nice presentation, Maria. And we have time just for a couple of short questions. The first is about the impact of the symptoms, of the severity of the symptoms in the relation between the therapy and EEG changes and improvement. And if you can explain if there are some specific frequency bands normalized by the treatment.
Mm-hmm. Do you hear me?
Yes.
Yeah.
Okay. Okay. What happens here? We did we use Vareta for the source analysis, and Vareta is including the normalization of the signal of all the recordings after the previous or the first and second step of the procedures to calculate the source imaging. And after that, we enter in the canonical analysis, the canonical correlation analysis, and we use only, we put the threshold, and we use only before and after the threshold, only the significant voxels. We are working with the voxels, the source analysis. And after that, we plot in the map. If we put for every single band, the areas. But the problem with this methodology is we didn't employ a reduction of dimensionality. This is more than 40,000 voxels. And in this moment, this is only the map with the significance before and after the threshold. For one more specific answer to you, we need to do a special or a specific other procedures, but we are doing now, developing a new toolbox with Bosch to give a more specific answer by each frequency band.
Thank you very much, Maria. I think that now we have to move to the next and last speaker of the session, Vasily Cisarev. Sorry for the pronunciation. You can upload your presentation and start. Thank you.
Okay, thank you very much. So the topic of my presentation is some perspective in the treatment of Parkinson's disease using completely new technology. And now I would like to tell a few words about this technology. Recently we developed it, we published it, and now this our presentation about it. So as you know, Parkinson's disease is very common, unfortunately, neurodegenerative disorder when affects predominantly dopamine producing neurons in specific areas of subcortical structures of the brain, first of all in substantia nigra, and symptoms generally develop slowly over the years. They are pretty huge, but many of them are tremor, rigidity, and some other neurological problem. Many of us saw such patients, and we can observe them sometimes. It is a really common disease. And the first line drug or chemical agent to suppress symptoms of Parkinson's disease is LDOPA or L-DOPA, which is still the most effective pharmacological agent for the treatment of at least motor symptoms in Parkinson's disease. Almost 4 decades after it was first used. It's a very classical medicine. But unfortunately, L-DOPA has not only advantages but also disadvantages. It has a side effects like nausea, some hallucination, and some other problem. And even more important, what slowly effectiveness of L-DOPA getting worse and worse, and finally it stops suppress symptoms of Parkinson's disease. So another therapy strategy of Parkinson's disease is a deep brain stimulation, or DBS, which is a neurosurgical procedure that uses implant electrodes and electrical stimulation to treat some problem, to stimulate neurons and to make them release more dopamine. It's now we can see how it works. During the stereotoxic neurosurgical intervention, we can implant the special electrode in the targeted subcortical structure, usually a substantia nigra, and the electrode is connected with the cap installed on the skull surface. Under the skin, the cable connect the pool of electrodes with pulse generator or stimulation controller, which is located under the skin. It can be recharged wirelessly by some device which is located out of the body, and continuously it sends square pulses to the neural tissue to stimulate it, and it can improve the situation dramatically. So it's not completely clear how it works, but we know what it electrical stimulation stimulate dopamine releasing from the neurons, stimulate activity of astrocytes. First of all, stimulates calcium waves in astrocytes, in astrocytic syncytium. It also make effect on the blood-brain barrier. It's a complicated story, and still now there are many very serious research about mechanism of deep brain stimulation, how it stimulate inhibitory afferent and excitatory afferents, and what's exactly happened with blood-brain barrier, how electrical stimulation can activate microglia and change some local immunity reaction. But anyway, by applying of electrical stimulation, we can increase activity of dopaminergic neurons, and it's improve situation of patients very seriously. Unfortunately, deep brain stimulation as well as chemical treatment has not only positive but also negative effects, side effects. First of all, it's a relatively tough surgical operation. There are some risk of hemorrhage, there are risk of local brain stroke. The hole in the skull, despite it's located under the skin, it's a potential gate for infection, and so on. So the risk is relatively small. It's about from 5 to 10%, but it's still a risk. And also, after a few years, effect of deep brain stimulation getting smaller and smaller because of loss of dopaminergic neurons, because of connection tissue which is growing around the electrode and changes its electrical properties. There are also possible some small mechanical drive of the electrodes. Anyway, it works very, very well at the first few years after surgery, and after that we can unfortunately see decrease of the positive effect. So what is the option which can be alternative of deep brain stimulation as well as chemical treatment of the Parkinson disease? So the main idea what we still targetedly stimulate some particular neurons located in substantia nigra and sometimes some other subcortical structure. We can do it chemically using some special drugs, special pharmacological agents. We can do it electrically, but we need to implant some electrode into the particular brain structure. Anyway, it's a complicated and not 100% effective story. So what is an alternative? Alternative of the selective or targeted brain stimulation, targeted stimulation of neurons was invented a couple of years ago. It's optogenetics. It's a light stimulation. I will remind briefly what is this. By some molecular genetic manipulation, we can a neuron or potentially any other cells express channel rhodopsin or some other light-sensitive peptide. Usually light-sensitive peptide, transmembranic peptide associated with ion channels normally exists only in some very specific cells of retina in our eyes, because it's a physical base of our vision. And so any other cells in the organism has not such peptides. But using genetical manipulation, we can make them express light-sensitive peptides, and therefore we can control a membrane potential of these cells by light. We can excite or inhibit particular cells, depending on what kind of light-sensitive peptide was expressed, by light application. Not only blue light, sometimes other wavelengths are also possible. If we want to express channel rhodopsin, halorhodopsin, or some other light-sensitive peptides in particular cells of adult organism, potentially including human, usually we can use adeno-associated viruses, or AAV. It's a safe and artificially made viruses which we can use to bring genetic material, particular DNA, to particular cell. It doesn't transmit from organism to organism, but we can targetedly inject it into a particular part of the issue. And when we can stimulate these neurons, these particular neurons, by light. For example, by light guide, if it is experiments on a live and really behavioral animal. This is very brief figure which shows how we can use adeno-associated viruses to bring particular genetical material, particular DNA, to the small amount of cell to express channel rhodopsin only in these cells. If we want to express channel rhodopsin widely, we can do some, we can perform some genetical manipulation with fetus or with an embryo, but it's another story, it's another technique. So can we use, the question is, can we use light stimulation of particular neurons in human, in clinic, for the treatment of some neurological disorders, including, but not limited, Parkinson disease? The main question is what to do with. We need not only express light-sensitive peptides somewhere deeply in the brain, in the selective cells, but also we need to bring light source to the deep brain structure. What is quite complicated, because it's not a problem if we are working with cortex, which is close to the skull surface, to the head surface. And anyway, it's absolutely not a problem if we are working with animal. We can bring some light guide. We can use even transcranial illumination if it is a small animal with a thin skull and skin like mice and rats. But potentially with human, it will be a very big problem. So it's not a big deal to express channel rhodopsin in some cells deeply in the brain, but it can be a problem how to bring light into the deep structure of the brain. We need to locate, we need to place a light source somewhere inside the brain, what is quite complicated. But using our technology, it's become possible. I will describe experimental paradigm. At first, it's a routine practice now. We injected specific adeno-associated virus into the particular part of the brain. We was working with primary motor cortex, M1, but potentially it can be any area of the brain. And it's a routine and safe procedure, and it makes neurons express channel rhodopsin in a couple of weeks after injection. After that, at the same place was injected specially designed and developed nanoparticles. These nanoparticles is a key point of our technology. Being implanted into the brain tissue, they are staying into the brain parenchyma without any effects, but under X-ray irradiation, these nanoparticles produce lights. So it's kind of conversion of X-ray irradiation, X-ray energy into the light energy. And after that, we performed some physiological experiments with animals using EEG, evoked potential recording, and some histological control was done. At first, we used a live animal for the checking of activity of particular neurons using EEG recording, just transcranially, just from above the skin. And we saw what in response to an X-ray pulse applied to the whole animal, we saw very clear evoked response. It's a classical neurophysiology, maybe 100 years old, but it shows us what the cells, particular cells in the mouse brain, are sensitive to the brief X-ray pulse. And the next was the histological control. So we can see the green neurons in one hemisphere. It's the M1 primary motor cortex area where the adeno-associated virus has been injected, and where we can see expression of a channel rhodopsin, which is associated with GFP protein, GFP fluorescence. This is the left hemisphere, this is the right hemisphere, and only in the place where adeno-associated virus has been injected, we can see expression of GFP of our channel rhodopsin neurons. And the next, we applied X-ray irradiation during relatively long time when animal was sacrificed 2 hours later after X-ray application, and we used C-FOS expression. C-FOS is a special peptide which can be used as a activity is a marker of neuronal activity, because its expression is in proportional with neural firing before animal was sacrificed. So here we very clear can see a red fluorescence in the same area where we can observe green fluorescence. I will remind what green fluorescence is a channel rhodopsin and red fluorescence is a C-FOS. We can see it in the same area. It means what in response to continuously application of X-ray pulses, we can see a very significantly increased X-ray C-FOS expression. It's because of neural firing caused by X-ray irradiation. So finally, there are some conclusions. We synthesized some specific nanoparticles. They are biologically neutral, but in response to the X-ray radiation, they produce light. In our case, it's a red light, red part of spectrum, but potentially we can change it. These nanoparticles can be injected without any toxicity. They can stay in the brain, in the brain tissue, very long time. In our case, we are staying 2 or 3 months in the mice brain. And after that, we can absorb them histologically without any changes. We also can make particular neuron express channel rhodopsin, which is quite routine procedure. And if these channel rhodopsins expressing neurons located close to the nanoparticles, we can control firing of these neurons by an X-ray radiation. But X-ray is not a problem to penetrate. X-ray goes completely fluently through the skin, skull, and any other tissue. It's not a light. We don't need to use light guide to bring a light to specific neurons. We don't need any mechanical intervention. We don't need a surgery. So potentially we can inject channel rhodopsin anywhere in the brain, including human brain, including globus pallidum or substantia nigra or some other subcortical structure which is critical for Parkinson's disease and some other neurological disorders. We can apply X-ray radiation. By the way, it's a relatively small dose, compatible with the dose what we are getting when we are visiting dentist for the teeth X-ray, and we can control excitation or potential inhibition if it will be, for example, not channel rhodopsin but halorhodopsin by an X-ray radiation. So if this technology allow us to wirelessly control neural firing anywhere in the brain without any mechanical intervention, without neurosurgery. So in conclusion, I just would like to show this paper. It was published and we have received some positive and enthusiastic replies in response to this publication. The future plan is to increase as much as possible working in this direction. We need to synthesize new nanomaterials which can transform X-ray into the not only red light, red part of spectrum, but green or blue, because of different channel rhodopsins are sensitive for different part of spectrums, and we can combine them as a Lego elements. It's a very huge perspective, but it needs a lot of work. So we need to find the optimal light sensing proteins. It can be different type of channel rhodopsin, halorhodopsin, or some other opsin to inhibit or to inhibit particular neurons or to make them firing more and more. And the main idea, what we need to use the optimal combination of particular nanoparticles and particular opsin for particular neural disorder, not only for Parkinson's disease, but maybe for something else. We are thinking about epilepsy because deep brain stimulation can be used and it's usable for the treatment of hard epileptic seizures too. In conclusion, I would like to say thanks to many people who were working in our team, but first of all, it's Dr. Harihaya Zurunglu from University of Maryland. It's my boss, Dr. Yu Chen. He was in University of Maryland too, but now he moved to Massachusetts. And Dr. Elena Rashkova, who was in charge of synthesis of these nanoparticles. She is in Chicago. And these nanoparticles was made in her division in Argonne National Laboratory. Thank you very much for your attention. I'm done. Let me show all figures together.
Yeah, thanks a lot for this presentation. I think that this is really a window on the future, which is present. So it's fantastic. Of course, I encourage all attendees to ask for questions or clarifications on the chat. And I think that it's really, really exciting. I see that you think that this kind of approach could be implemented over years to give some therapeutical stimulations to Parkinson's disease patients or patients with other diseases. In this case, how could you manage the administration of X-ray in the patients over a long time, because they need to be continuously stimulated, with electrical stimulation. They come to home with the device and can receive beneficial effects over days continuously, because the battery is long lasting and so on. But with X-ray, how can you help them over time?
It's exactly the question what we need to think. Thank you very much. Of course, currently there are no portable X-ray devices which can be located on the patient head, and he or she cannot walk with an X-ray machine. So we need to think about protocol, because in case of deep brain stimulation, it is possible to stimulate neurons continuously all this time. 24 hours a day is possible. We can't do it by X-ray. So the person maybe need to come sometimes for some therapy during some particular time, regularly or non-regularly. Maybe we can think about feedback connection, loopback connection in case of epilepsy to detect epileptic activity, for example, by EEG, and immediately apply X-ray determined inhibition to suppress epileptic seizures at the beginning in case of status epilepticus or frequently appearing epileptic seizures. Anyway, it's a lot of things to do. So for the now we are just at the beginning. We published the proof of concepts, and by the way, we got a patent for this technology. But it needs a lot of work to introduce it from animal experiments to clinic.
Yeah, I'm not an expert of this field, so sorry if my question is naive. And could you an alternative thinking is to try to have this optogenetic neuromodulation by an emitter, a battery, allowing to the energizing the optogenetic stimulation similar to deep brain stimulation, electrical stimulation. So do you think that this alternative could apply to have the beneficial effects of inhibition and excitation in relation to the light?
Yes and no, because yes, potentially we can apply optogenetics technique in human. It's not a problem. Most of the scientists believe it's absolutely safe, but only in one case such manipulation has been approved by FDA in the United States for the optogeneticals manipulation with retina cells for the treatment of some eye disease. In other cases, was no reason still to apply optogenetics in human, because we can, of course, we cannot do it just for experiments, and there are no reason, or at least it was no reason to apply it in human for the treatment. Because if we want to stimulate some neurons locally in the brain, we can do it by electrodes. If we want to do it by light using optogenetics manipulation, anyway, instead of electrodes, we need to introduce into the brain light guide. But what is the advantage? Anyway, it's some mechanical device.
I think that you can control the not having the spread of the current from one side, and the other side is that you can produce some inhibition and excitation with different lights. So it seems promising when compared to electrical stimulation. And maybe you can use also smaller fiber in relation to electrodes, because you know that the electrodes can produce some neuroinflammation locally, but maybe with the fibers you can reduce this effect.
Yes, exactly. It would be amazing, and such experiments were done with animals, with rats, maybe, and it completely works. But it's still unclear, is there some advantage for the treatment of some particular disorders, for example, Parkinson disease. In case of Parkinson disease, we know what in the United States now about 60,000 of people with implanted electrodes in the brain. So it's a very reliable technology. And few tens of thousands who have an electrodes for some other treatment, not Parkinson disease, but epilepsy or essential tremor, it also works. But we still cannot be sure what some optogenetical technique can be dramatically better for particular disorders.
Thank you for your very, very clear discussion, and thanks a lot of people who follow our session. I think that we have at the end of the session, and so we can move to the central space of Zoom to follow the rest of the Global Brain Consortium annual meeting. Thanks a lot.
Okay,
Thank
you so much.
Wait a moment, please. Thank you so much, Professor Vasily, for your very informative presentation and talk, and Professor Claudio for your questions as well.